Hey everyone, welcome. Today, we're going to build a really solid framework for understanding something you'll see all the time in medicine, the microcytic anemias. We're going to break this down step by step so you can tackle it with confidence every single time.
So let's start with the scenario that's going to be your bread and butter. You get a lab report back and you see that MCV, the mean corpuscular volume, is less than 80. That one little number tells you the patient's red blood cells are too small, and right away, your brain should start firing off a list of possible causes. So, what's on that list? Let's dive in.
Here's our game plan. First, we'll cover the absolute fundamentals of what makes a red cell small. Then, we're going to walk through the three big categories of causes, kind of like we're working up a few different cases. And finally, we'll pull it all together so you can easily tell them apart.
All right, let's dive right in. Before we can figure out what's going wrong, we have to understand how it's supposed to go right. We need to look at the normal hemoglobin blueprint because honestly, this is the foundation for everything we're about to discuss. Okay, so what exactly are we talking about here? Well, the name kind of gives it away. Microcytic just means the red blood cells are too small. Hypochromic means they're paler than usual because they're not filled with enough hemoglobin. But the real question is why? Why would the body start making these tiny, underfilled red blood cells?
And here is the absolute key to understanding all of this. You can boil down almost every cause of microcytic anemia to a problem with the hemoglobin assembly line. See, you need two main parts to build a hemoglobin molecule. You need the heme group and you need the globin chains. If you have a problem with any of the building blocks, the iron, the protoporphyrin ring, or the globin chains themselves, you can't make enough hemoglobin. And if you can't make enough hemoglobin, the cell ends up small and pale. It's that simple.
Okay, first up on our list of culprits is iron deficiency. This is, by far, the most common cause you'll see. And it's really a supply chain problem. It's all about a missing raw material for our hemoglobin factory. It's pretty straightforward, right? The body just can't make the heme group because it doesn't have enough iron. The factory has run out of steel. Now, this can happen for a few reasons. You could be losing it, usually from chronic bleeding like in the GI tract or with heavy periods, or maybe you're not getting enough in your diet, or you can't absorb it properly. And sometimes your body just needs more than usual, like during pregnancy. The lab tests for iron deficiency really paint a perfect picture. Of course, your serum iron is going to be low, and so is ferritin, which is your body's iron storage protein. The tank is basically empty. Now, in response, the body starts to panic a little. It increases the total iron binding capacity, or TIBC. That's the liver pumping out more transferrin, which is the protein that transports iron, desperately trying to find any scrap of iron it can. And the RDW, or red cell distribution width, is high because you have this mix of newer, tiny cells being made alongside older, normal-sized cells.
Now, besides just feeling tired and looking pale, you need to keep an eye out for some really specific clues. Chylonychia, or spoon nails, is a classic sign, and so is pica. That's the strange craving to eat things that aren't food, like ice or even dirt. That's a huge giveaway. And you always have to remember the triad of Plummer-Vinson syndrome. That's the iron deficiency anemia, plus webs in the esophagus causing difficulty swallowing.
All right, let's switch gears. Our next case is a totally different kind of problem. This is thalassemia. And this time, the factory has plenty of steel, plenty of iron, but the genetic blueprints for building the globin protein chains are all messed up. Okay, you absolutely have to know the difference between alpha and beta thalassemia. It's super high yield. Alpha thalassemia is caused by a gene deletion on chromosome 16, where we normally have 4 alpha globin genes. Beta thalassemia, on the other hand, is caused by a point mutation on chromosome 11, where we have 2 beta globin genes. Their typical geographic prevalence is also different, which can be a clue. I love alpha thalassemia because it's such a perfect example of a dose-dependent effect. It all depends on how many of those 4 genes are deleted. If you lose 1, you're a silent carrier, totally fine. Lose 2, you've got a mild microcytic anemia. Lose 3, and you get hemoglobin H disease, which is more severe because those leftover beta chains form toxic clumps. And if all 4 genes are deleted, it's incompatible with life, a condition called hydrops fetalis. Now with beta thalassemia major, sometimes called Cooley anemia, the problem is you can't make enough beta globin chains, which are essential for adult hemoglobin. This is why babies with this seem fine at first. They're still using fetal hemoglobin. But then, around 6 months, when they're supposed to switch to adult hemoglobin, things go south. They get severe anemia, and their bone marrow goes into overdrive trying to compensate, which can lead to that classic crew-cut appearance on a skull X-ray.
These patients need lifelong blood transfusions, and their labs will show high levels of other hemoglobins, like HbA2 and HbF, as the body tries to make up for the deficit.
Okay, on to our last major category. We've talked about missing raw materials, and we've talked about faulty blueprints. Now we're talking about a broken assembly line. This is where you have defects in making the protoporphyrin ring itself. You've got the iron, but you just can't use it.
So lead is basically a saboteur in our hemoglobin factory. It comes in and just wrecks two critical enzymes in the heme synthesis pathway. It takes out ALA dehydratase early on, and then it knocks out ferrochilitase at the very end. That's the enzyme that actually sticks the iron into the ring. So with lead poisoning, heme production just grinds to a halt.
There's a great mnemonic for the classic signs of lead poisoning. Just remember LEAD. The basophilic stippling you see on a blood smear is a really key finding. It's basically clumps of leftover ribosomes that the poor, damaged red blood cell can't get rid of properly.
Now this one is super interesting. Sideroblastic anemia is the classic iron-loading microcytic anemia. Here, the cell has plenty of iron, but it can't use it because of that defect in protoporphyrin synthesis. So the iron gets delivered to the cell's mitochondria, but it just gets stuck there, piling up around the nucleus. When we do a bone marrow biopsy and use a special iron stain, we see these beautiful but pathological ringed sideroblasts.
Sideroblastic anemia can be genetic or acquired, but the thing to really remember is that it can also be reversible. The big reversible cause to know for your exams and for the wards is alcohol abuse. But also think about lead, certain drugs like isoniazid, and vitamin B6 deficiency. And this is where the labs are the complete opposite of iron deficiency. They show iron overload. High iron, high ferritin, and a low or normal TIBC, because the body isn't looking for more iron. It knows it has plenty.
All right, time to bring it all home. Let's synthesize all this and put it together in a way that makes sense. This next slide, this is your money slide. This is how you're going to put it all together in your head and on the wards.
Okay, let's walk through this, because it's so important. Look how the iron studies create a beautiful branching point. Iron deficiency is the only one where serum iron and ferritin are low and the TIBC is high. The thalassemias and lead poisoning tend to have normal-ish iron studies, but sideroblastic anemia is the only one with that classic iron overload profile, sky-high iron and ferritin, with a low TIBC. Then you look at the smear. Target cells should make you think thalassemia, and basophilic stippling points you toward lead poisoning or a sideroblastic anemia. See how you can work through it?
So let's wrap this all up. When you're in the clinic and you see that lab report with an MCV less than 80, I want you to think back to that hemoglobin blueprint. Think about the raw materials, the blueprints, and the assembly line. Based on everything we just covered, what are those first few tests you're going to order to start sorting this out? Think about it. We'll see you next time.